Hello everyone, and welcome to the first in our hopefully series of webinars aimed at the public contributors in research techniques and study design and all the other things that we try to cover in our face-to-face events that some of you will be familiar with. So a big welcome to everybody who's been able to join us. We've been delighted that we can extend these out wider than we would normally be able to do when they are face to face. So just a few words before I welcome our speaker on housekeeping. So we'd love to have your feedback and your questions for Lucy. So please use the Q&A function that you should be able to see, which will be either at the top right or the top left of your screen. Just be aware that there is a moderation process with the questions, so there might just be a slight lag in your question actually showing. So we're also going to post in the Q&A a shared email address. And if anybody does have any technical difficulties or has any feedback, please do share that. As our first event, I'm sure that it might not go as smoothly as we hope it will. So we'd be really keen to try and refine these as much as we possibly can. So please do feel free to share your experience. So I'm just going to briefly introduce Lucy. Lucy is a health economist with the Department of Primary Care Health Sciences at Oxford University, and her research looks at the cost effectiveness of patient interventions in primary care with a consideration of quality of life. She's going to tell us some of the key points about health economics and why it matters, particularly for healthcare professionals, but also very much for patients and the public. So thank you very much, and over to Lucy.
Sorry about that. I just had a little moment trying to work out where the mute button was. Thank you very much for joining. So as Claire said, my name is Lucy Abel. I am a health economist in the Department of Primary Care, where I've been for 5 years now. And I think in one of the adverts, I gained a rogue doctorate. I'm actually studying for my DPhil at the moment, so I'm not yet a doctor. Will be in a couple of years, if only we're a couple of weeks. So today, what I want to talk to you about is health economics, and kind of wanted to go for a bit of a split between some motivation and some background and why we need health economics, and then a little bit about the kind of study designs that you might see in a health economic study, and really what a health economist might be looking for from PPI feedback. So, as I said, starting with a bit of motivation and then switching into how we do cost effectiveness analysis, which is going to be the main focus today, because that's the thing that you're most likely to see as a PPI participant. So we're going to start with the health budget, and actually I'm going to take a little detour and talk about booze for a minute. So I've chosen champagne because I don't know if you know this, but apparently it's day 3 of Royal Ascot today. And the reason I wanted to talk about alcohol is because from a health point of view, it's pretty terrible. It's responsible for 300 on average A&E attendances per day, and that's just for alcohol poisoning itself. That's not car accidents, that's not domestic violence or anything like that that's associated with alcohol, just alcohol poisoning. We see over 12,000 deaths from alcoholic liver disease per year. Up to 17% of children, based on a recent study, show signs of fetal alcohol spectrum disorders, which is not fetal alcohol syndrome, but it's some of the sort of traits that we see associated with that disorder. And Public Health England has estimated that the societal burden is somewhere between 27 billion and 52 billion pounds per year. So this is a huge problem. And yet, almost every health professional I know still drinks. So why is this? This is because of a concept that we health economists and economists more widely call utility. What that means is the things that people choose to try and improve their well-being. So that might be choosing to drink, whether to survive lockdown or at a wedding or whenever. It might be choosing to eat healthily because you think it's good for you. It might be giving money to charity. It could be any of those things. And it's important to take into account this utility, because what it tells us is that health is not the only thing that matters to people, that if what we're interested in is maximising societal well-being, we need to take into account more than just health. And the reason that that matters is that when we think about the healthcare budget, we need a healthcare budget. We can't spend all of the money that exists in the world on health, because we know that that's not what's important to people. We know that health is important to people, but we know that there's lots of other things that are also very important. Sometimes those things are completely counter to health. So when we're thinking about the healthcare budget, what I've put up this graph here is the NHS healthcare budget since the NHS was founded in 1948 up until 2017. And what it shows us, we're looking at the blue line, the first thing that you see is that it's increased dramatically over time. There are various reasons for this. It's not completely clear why this has happened, but a lot of it is just that healthcare has improved an awful lot in 70 years. So conditions that would have led to very early death back in the late 40s, we can now live with and survive and thrive even for 10, 20, 30, 40, 50 years, which is fantastic news. So healthcare has improved a lot, but as people live longer, as healthcare becomes more effective, it then means that the budget goes up. Someone who would have died when they were 50, now living to 80, incurs 30 years more healthcare costs than they would have done otherwise. The other thing is that with not knowing why this healthcare budget is as high as it is, we need to consider whether that healthcare budget going up has been productive, whether that's an effective way of spending money, whether that budget has gone up for good reasons or for bad reasons. And the only way we can really know this at a country level is by doing international comparisons. So this is some data from the OECD. You probably won't be able to read the countries along the bottom. That's fine, you don't need to. But what this allows us to do is to compare health spending between different countries and to start to map it onto health outcomes. So we can decide whether that health spending that we've got is good, whether it's resulting in good health outcomes, or whether maybe it's a little bit wasteful or we're spending it in the wrong areas. So these are two graphs from the OECD. The first one, as you can see, is health spending as a percentage of GDP. So that's how much of a country's total spending goes to health. And the second one is life expectancy at birth, which is a relatively objective measure of how healthy a given society is. And what we can see if we start to look at specific countries, and I've taken 3 examples, is that health spending varies very widely. Up at the top there, we've got the USA, spends more on health than any other country in the world. The UK sits sort of about 10th place, relatively mid-level spending. And then we've got Iceland, quite a small country, quite a small GDP, and spends relatively less money on health within that country. What we'd maybe expect if the health budget directly tracked onto health outcomes would be that those positions in that ranking would stay the same, that the USA would be right onto the right there, the UK approximately the same position, and Iceland in the same. Instead, we see the opposite. So we see that the USA drops way down the rankings in terms of life expectancy. The UK stays a little bit similar, but drops ever so slightly, and Iceland shoots up and has the 3rd highest life expectancy of the OECD countries. So why is this happening? Well, it can happen for various reasons. One is that we sort of know that in health, the health budget will expand to take as much money as you throw at it. It's a hugely labour intensive industry, which means that as things like salaries go up, spending goes up. And what we see in the US is that doctors are paid more than they are in other countries. At the same time, there's also a much more complex system because they have a system of private insurance, unlike in the UK with our National Health Service. So what that means is that there's lots of extra staff doing things like processing insurance claims. And that all adds up to increase those costs. The other thing that they have, being a private system, is a system that's still heavily influenced by what we might call fee for spending services. So this means that if you go to the doctor and the doctor does something to you, they then claim that back off the insurance company. And what that does is it creates a system where they have an incentive to do more stuff, regardless of whether that stuff actually results in health outcomes, good health outcomes or not. In the UK, we keep a bit more of a cap on that because we pay, for example, per capita. So doctors will receive a certain amount of money based on how many patients they have to treat and based on how well those patients do in terms of their health outcomes. And that keeps a cap on this sort of extra spending that goes on. But the main takeaway from this is that health spending is not an unalloyed good. We need to be careful about how we do increase that health spending so that we can make sure that it's doing the things that we need it to in terms of health outcomes, rather than just going into the pockets of an insurance company. So together, from alcohol to the health budget increasing over time to international health comparisons, we can learn three sort of fundamental truths. The first is that we do not have an unlimited appetite for health. There are things that compete with health for our attention as a society. There are other things we want to do, whether that's drinking or skydiving or driving a really fancy car really fast. The other one is that the healthcare budget is increasing and does increase. And then related to that is that that increase does not necessarily lead to better health, which is the thing that we're really interested in. And these are sort of the foundational truths of health economics. This is really what underpins the whole field, is knowing these three things and trying to work out what to do about them. And it results in three questions. The first being, what is the appetite for health? Relative to all those other things we could spend money on, how much money should we spend on health? How much do we care about it? The second one is, how should the healthcare budget be determined? And then again, this relates to the first one. If you know how important health is, you can then decide how big or how small should we make that healthcare budget, given that it needs to come out of taxation and things like that. And then the final one is, how should we allocate that budget to maximize health? Because we know that that doesn't happen automatically. So this is the motivation. This is why we do health economics in the first place. And really what we're interested in most research that I do, and that if you're a PPI participant, you're likely to encounter, is going to be that third one, that question of how should we allocate the budget to maximize health? We're going to move on to research now, which is much more of the practical stuff. And broadly, there are three types of health economics research study that you're likely to see. The first one is what we call econometric studies of health systems and policies. So what those are is statistical analyses using data sets that already exist to work out whether the health system is working the way it's meant to work out what policies might improve it, and to see with those past policies whether those policies that have been implemented have worked. The second one is surveys or experiments that are all about understanding people's preferences for different health outcomes. So if you've ever come across a quality of life questionnaire, that's going to have been developed using this second type of study design, these surveys and these experiments, to try and work out what people's preferences are. And then the third one is the one I'm going to focus on more today, which is about evaluating whether a treatment is cost effective. Of these three study designs, the first one, the econometric one, is the one that's least likely to have PPI involvement on the whole. They tend to be very statistically heavy. I think they probably would benefit from more PPI, but for now, they tend to sort of stay in the realm of a economist hidden behind their computer. The other two are much more likely to involve PPI participation. I'm going to focus on the third one, evaluating cost effectiveness, because the second one is generally, as a PPI participant, relatively self-explanatory. It's much more just about which of these outcomes do you prefer and things like that. So you don't need quite as much training to be able to contribute meaningfully to those ones, whereas the cost effectiveness ones is maybe a little bit outside some people's experiences. So that's what I'm going to focus on for the rest of this talk. So cost effectiveness collectively is known as economic evaluation. And the reason for this is because cost effectiveness itself is a type of economic evaluation. So you sometimes see them used interchangeably, but technically economic evaluation is the umbrella study design. And the question we're asking when we're asking about economic evaluation is, are the additional benefits of a new treatment worth the costs? The key word I want to draw your attention to there is additional. So in the health system at the moment, in general, we're usually talking about things that we can already do for patients. There's very little that we don't treat at all in the health system nowadays. So generally, when we've got a new treatment that we're thinking about bringing in, we're talking about additional benefits over what's already done. That's really important because the comparator, the thing that's already happening, what we might call usual care, is going to really influence how cost effective the new treatment is. If the existing treatment is already really good, then maybe the new treatment, even if it's sort of good on paper, if it's not that much better, but it costs a lot more, there's not that much point paying for it, or it might be a lot harder to justify paying for it. So I mentioned that there are types of economic evaluation, and one of them is cost effectiveness. So cost effectiveness strictly is when you result in a cost per outcome result, which we'll talk about a little bit more later. And this could be a cost per case identified, it could be a cost per life year gained, it could be a cost per person treated or something like that. These are often condition specific outcomes. So we're not talking about health in the generic sense, we're talking about health in a condition specific way, so a cancer specific or an asthma specific way. The other type, which is the one that is a little bit more preferred, is cost utility analysis. And this is cost per health outcome, but in a universal way. So if you've ever seen quality adjusted life years talked about, they're usually abbreviated to QALYs. They're a little bit controversial, but what they're for is they're about taking those clinical effectiveness measures and turning them into something universal. And so cost utility analysis is one of the ones that you'll see most frequently if you're involved in something like a clinical trial. And then the third type is the simplest, which is cost minimization. And cost minimization is what you do when you've got two treatments that work about similar effectiveness, no real differences there, and you just do an analysis to see which one is cheaper. So those are the three main types of study design that you might come across. Once you've done your analysis, you're going to end up with some results. And really the easiest way to understand the results of a cost effectiveness study is to plot them like this. This is a cost effectiveness plane. And if you are involved in a study and you don't see one of these for the results, ask for it because they reveal all the secrets. You don't really need to know any statistics to understand cost effectiveness, you just need to see one of these charts. And the reason for that is because they're relatively self-explanatory. What we do is we take the difference in cost and the difference in effect and we plot it. And where we plot it on this plane tells us so much about whether something is cost effective or not. And the reason for that is because which square it is, which we call quadrants, which quadrant it is in, really tells us something about whether we want to pay for it or not. So if you look in the top left, the one with a big square through it, that's a big cross through it. That's a treatment that is both more costly than the current care and is also less effective. So we never want to pay that. We'll never want to pay for this treatment because we could just stick with what we've already got and we get both better outcomes for patients and we save some money. The reverse of that is if you follow down to the bottom right, you see the complete opposite. In this case, we always want to pay for that treatment because it costs less than what we're doing currently and it's more effective. Where it starts to get a little bit interesting is in the bottom left and the top right. So in these situations, we've got treatments that are either less effective but cheaper or more expensive but better. The ones that show up in the bottom left, when the NHS is making decisions about those, they typically tend not to pay for them. It's a little bit controversial because we could do that and spend that money on things that are in the top right or things that are in the top left. So there's definitely an advantage to disinvesting in favour of something that's cheaper, even if maybe it's less effective. but obviously it's a little bit controversial. And so for now, at least, the NHS has largely avoided paying for something that is cheaper but less effective. Individual CCGs and so on, they might make their own decisions, but at the national level, that's generally what's happened. On the top right corner, that's where all the drama happens. That's where all the fun stuff is. So how much more should we pay for something that's more effective? And this is when you read in the news about NICE, which is the NHS cost effectiveness body, making a decision on a drug and they say it's too expensive, it's not good enough. That's always going to be something that's in that top right corner. And that's where most drugs tend to fall nowadays, most new drugs, because drug companies need to make some money, so they'll typically try and aim for something that is more effective and then charge more for it. And so that's really where in that quadrant that little star sits, is what's going to determine cost effectiveness. And there's a whole body of research about how we work out where that line is. So I want to talk a little bit about the kind of methods that you might see, because at the moment I've been quite general, so I'm going to go into a few specifics just for the last 5-10 minutes, give you a little bit of detail. So the standard method that you're going to see in a cost effectiveness study is that you're going to try and, the health economist first has to try and obtain your clinical evidence of effectiveness for a certain treatment. So this is your standard outcomes that you might see from a trial or a systematic review or anything like that. Normal science. Normal science spits out a measure of effectiveness. And that measure might be a survival time. In cancer, it might be a tumour size. In diagnostics, it might be the number of cases that you've detected, something like that. What they're then going to do, if they're doing cost utility analysis, is they're going to convert that effectiveness measure into a quality adjusted life year. So the way that they do that is they take, say if it's survival times, they'll use those survival times to get a life expectancy. And then the number of years gained from that life expectancy will then be adjusted using a quality of life measurement. And how we get those quality of life measurements are usually through questionnaires, and the most common of those is called the EQ5D. But there's various questionnaires around that we can use to try and measure people's quality of life. So having got their quality adjusted life year, or their universal health outcome, in low-income countries, instead of quality adjusted life years, we tend to use disability adjusted life years, which are called DALYs. So you might sometimes see them as well. Basically, the point is there are multiple universal health outcomes that can be used. Having got our universal health outcome, we're then going to try and get hold of some costs. So costs, again, we might obtain from electronic health records. We might obtain them from central costing sources. So the NHS produces some evidence of costs that we can use to work out how expensive things are. There's obviously things like the British National Formulary, which is the medicines price list for the NHS. And what we're then going to do is combine those in the way that you just saw in the previous slide with our stars on our cost effectiveness plane. Essentially, you find your difference in cost, you find your difference in qualities, and then you map onto that plane. And we can make a judgment, and you can do, in addition to that visual judgment, you can also do a mathematical one, and that's going to generate your statistics that you need for cost effectiveness research. And there are two main kinds of statistic. There's the incremental cost effectiveness ratio, or the ISA, and you might also see net benefit reported as well. I'm not going to go through how we calculate these because it's not particularly interesting, and I just want to talk about where those numbers come from rather than how they're specifically generated. Really, the main thing that you need to see is that cost effectiveness plane as a PPI participant. That's what you're looking for. So that's the general method that we're looking for. There are a couple of specific study designs that we can also use. There are sort of two main study designs that you're likely to see. The first is a trial-based evaluation, and the second is a decision model. So a trial-based evaluation is if you're doing a trial or an observational study or something like that, you can stick on top of it an economic evaluation. And the way that you do that is that in addition to collecting all of your clinical evidence, you'll also give the people in your trial a quality of life questionnaire. You might give them a resource use questionnaire, so they write down how often they've been to the doctor and things like that. Or you might look at their electronic health records to see how often they went to the doctor, and that's going to give you your costs and your quality of life as well. And then you can just do that basic mapping that we've already seen, that sticking those numbers onto that plane to get your cost effectiveness estimates. The other way that you can do it is to use a decision model. A decision model is a little bit more complex, but what's useful about that is that we can simulate a lot more of people's experience of healthcare. So a trial, we might be able to follow people up for a couple of years. A decision model will try and map their entire life. And that's really useful because it means that when we're thinking about what things cost, if there's a treatment that we can give someone now, but it's going to extend their life by 30 years, which is something that we're starting to see. There was a case recently about a cystic fibrosis drug that potentially has the potential to do that. In those cases, you really want to be able to map that person's entire life, so you can measure all of the benefits and all of the costs associated with that drug over their lifetime. Obviously, that's a little bit harder to do. It's a little bit more involved. And it generally, the evidence you'll take without having a trial that you can measure that evidence from directly, you have to go back to published papers and you have to do a systematic review and things like that to get the evidence that you can then build into your decision model. I'm going to show you a little map, a little conceptual figure of a decision model, just so you can see what they look like. This is something that you would maybe see if you were a PPI participant on a cost effectiveness study. You may well see a diagram that looks a little bit like this. And the way to read it is just to go from left to right. So we start on the left and we've got a patient with symptoms. Now the technology under evaluation here is a new test. Previously we weren't testing patients, now we are. So if you look at the top, we've got a new test, and if the patient gets that new test, then they've either got the disease or they don't have the disease. If they have the disease, they can either test positively or test negatively. So just looking across the top of your screen, across the top of this figure. So if someone gets a positive test and they have the disease, we've ended up paying a little bit more for their care because we paid for this new test, but they're going to have better outcomes, which is great. So we've got a good outcome there. On the other hand, if they have the test and they test negative, but actually they've got the disease, what we'd call a false negative, we paid more for the test, but actually they've ended up with worse outcomes because tests are usually a little bit inaccurate. They're very rarely 100% accurate. And actually this is, in a timely way, this is something that we've seen a lot with coronavirus. The coronavirus tests at the moment have a big problem with lots and lots of false negatives. So lots of people who have the disease are showing up as not testing positively for the disease. And so then they go out into their community and spread it around. So this is a huge problem for science right now. So what we're doing when we're building a decision model like this is we're essentially mapping patients moving through the care pathway. We're mapping them through their healthcare experience. Now this is relatively simple, this decision model, because they just have a single test. But they can get a lot more complex than that. And what would happen then is that your decision model would just get longer. You just need a wider screen to be able to see the treatments that come after that test and so on. If you're helping with a decision model, if you're doing PPI and there's a decision model showing up somewhere, you would expect to see this kind of diagram. And what you're looking for when you're reading it is just checking that your experience is somewhere in there. So if you had the disease and you had a test, then you'd be like, yeah, that looks like what I experienced, that's fine. But if, say, there was an additional step in there somewhere where you had to have a referral before you got the test or something like that, you might just say, well, my experience isn't in there. And that's going to flag to the researcher that they need to tweak their model slightly, which is incredibly helpful from the health economics point of view. So just to wrap up, I've already, as we've been going along, talked a little bit about what PPI participants can really contribute to health economics research, but just some specifics. As I've said throughout, a lot of how we do these valuations is through quality of life. So checking that the quality of life that we're building into our quality adjusted life years and so on actually match your experiences is incredibly important for us. We are really focused on what your health actually looks like. So we're not really interested in tumour size, we're not really interested in how you're doing on a certain asthma score or whatever. We want to know what your quality of life looks like. That's what we're trying to pay for. That's what we're trying to measure. So if there is something that's not being captured, then it's really useful for us to know that. The one caveat to that, and I put it in italics there, is we want to know the changes in your experience. Obviously, we can't measure your entire quality of life experience. We can only measure a tiny little bit of it. So what we're looking for is, will this intervention we're evaluating change your experience? And will those changes be captured in the way that we measure quality of life? The other way that PPI can really contribute is in study design. So I already mentioned earlier, we need to know what the relevant comparators are. So what does usual care look like? And obviously that's going to be really reflective of what your personal experience might have been in the healthcare system. Does what the health economists think usual care look like map to your experience? Similarly, are your experiences represented in the decision model? If there's a decision model and you see a diagram of it like that, can you kind of see yourself in there somewhere? You might be simplified, but are you in there? If not, that's really helpful for us to know as well. Finally, how are costs affected by this condition? And usually in a lot of cost effectiveness studies, we'll only be looking at healthcare costs, so health system costs, what does the NHS pay? But if you are incurring a lot of personal costs because of your condition, that's something that we can start to think about including in our studies as well. Where that is the case, we do have mechanisms for doing that, and that's really helpful to know. So if you are having to spend a lot of money traveling or something like that, then it really helps for the health economist to know that. And then finally, if you're involved in a trial and there's a cost effectiveness analysis, I've mentioned we use quite a lot of questionnaires in cost effectiveness analysis. So knowing the burden of that is always enormously helpful for us. Finding out that maybe there's 45 questionnaires in this trial, do flag it to us, because we will get carried away a little bit trying to measure things. So that's all I wanted to say today. Thank you so much for coming, and I'd love to answer some of your questions.
Thank you. Thanks very much, Lucy. That was a really fantastic, succinct overview of health economics in a short time. So we've got quite a few questions that have come through, so I'm just going to go through them with you and get some of your input. Our first question is from Tony, and he's asked about public versus private spending.
That's a very general question. I suppose, what do you mean by public versus private spending? I'm going to take it as, is private spending good or is public spending good?
What he might have meant is perhaps to do with how healthcare systems are funded, thinking about
yes,
private health insurance or kind of public and government funding.
Okay, I see. In general, private spending is more expensive. As a rule, private spending will always end up increasing your costs slightly. And that's for reasons like what I said before of administrative complexity. So if you're having to make insurance claims and things like that, you need an additional layer of people to manage all of that. And then the other one is that with a private system, there isn't really any upper cap pushing down on those prices. So drug prices tend to spiral because essentially people are willing to pay a huge amount for their healthcare. And that means that there's no upper cap on drug prices coming from patients themselves. What you get with a public system is that there is an impartial external person who's evaluating what's worth paying for and what's worth not. So in general, as a rule, and there are always exceptions, private spending will be higher for equivalent health outcomes than public spending.
Thank you, Lucy. That's great. So we've got another question that's coming from Gail, and she's asking about the utilities and the concept of utility. So she's saying that is well-being in the context of a utility more about emotional and psychological well-being, in other words, to try and make them feel better, or more accurately, is it to feel? Is it more about how they want to feel? So is it more? Is it sort of? Is it more than an? Is it a more objective measure of well-being?
This is a huge area of research. How do we actually measure these things? There is a whole field of economics called welfare economics, which is all about how we do this and how we measure it. It's really tricky to kind of say. It's really tricky to say that someone's well-being is objective or not objective, because you start to slip into the territory of saying that some feelings are perhaps more valid than others, which in general we sort of try and shy away from doing. So we're looking for things that make people feel better, but people don't always act in a way that makes them feel better. The thing about utility is it's not an objective external thing. It's a concept that helps us understand why people make the choices that they do. So really anything that drives the choices that you make can be said to be increasing your utility. So I think that's really important, that we're not trying to measure something that is this external out there thing. People don't walk around saying, oh, you know, I've got to maximize my utility today. They just act the way they do, and utility as a concept helps us understand why they act that way.
Thanks for that explanation, Lucy. Just to follow up from that, also from Gail, when we talk about cost effectiveness, are we talking in terms of the outcome of the treatment overall, including societal costs as a result of the individual's condition? So, for example, lost tax revenue. In general, no. You can do this. Some studies do take what we call a societal perspective, and they will include things like lost productivity. The NHS, as a rule, doesn't. It's an area of a lot of debate. The reason we don't at the moment is because there's a risk that you're then prioritising things other than health. So the NHS budget at the moment, its goal is to maximise health. If you start taking into account lost tax revenue, lost productivity, what will end up, the risk is that you end up paying more for health interventions that get people back into work and things like that. And that's not then maximising on health, that's maximising on those benefits as well, those economic benefits. We don't want to do that because at the moment the sort of rule of thumb is that all health is equal, everyone's lives matter equally. What we're concerned about is how we improve your health outcomes, not how much you contribute to the economy. Great, thank you, Lucy. There's been a couple of comments that have come up in the question about the idea of the so-called postcode lotteries. So the decisions of individual CCGs to implement healthcare strategies, rather than perhaps rather than taking it from a more national overview. Can I get you to comment on that, Lucy?
Yeah, I think it's a really good point to keep raising. So NICE, the main decision maker, was essentially established to try and counter the postcode lotteries. NICE has a mandate. So if NICE says that something has to be paid for, something has to be paid for, no matter where you are in the country. And that was precisely established that way so that you're not subject to these postcode lotteries. But other areas of spending, that's less clear. As has been pointed out in the comments, there's individual CCGs now, and they now have a mandate of their own. And if something's mandated by NICE, it has to be covered, but anything that's not been subject to an explicit guideline from NICE or an explicit decision from NICE is kind of up for grabs. And so what we are seeing is that as particularly local authority or public health budgets are squeezed, as the NHS is having to kind of do more with either less or the same amount, CCGs are looking for opportunities to cut some things. And sadly, what's being cut isn't the cost ineffective stuff. One of the things that's really suffered in the last 10 years has been joint replacements, which are one of the most cost-effective interventions we have. But because you can extend the waiting times, you can just reduce how many operations you do in a year. It's a really easy one to sort of quietly reduce spending on, even though actually it's an incredibly cost-effective procedure. So that is happening. It's really tricky to say how you solve that problem without just more mandates. I think probably more local authority, more public health, more social care funding would go a long way to starting to free up some of the NHS budget so we can pay for some of these things. But yeah, at the moment, it's the postcode lottery has kind of crept back in. We need to be really aware of that.
That's a really, really interesting point, Lucy, and thank you for sharing that. There's a few sort of comments around that sort of theme, so I'm going to stick with some of those. And somebody's put here that what if there was clear evidence from abroad, but it didn't pass an HTA assessment or a NICE panel? Are there kind of any situations like that?
There's a lot of those situations. They're really common. And again, it comes back to different countries having different sort of willingness to pay for things. So we can use international effectiveness evidence. So a big clinical trial that was in Europe or the US can absolutely be used in your HTA, your health technology assessment or your cost effectiveness analysis in this country. What you can't use is the same costs, because different countries have, they pay their doctors different salaries, they pay their nurses different salaries, all of those things are different. So you need to have country specific costs, but you can use international effectiveness evidence. The question of why something might be approved in one country and not in another, I mean, we saw the difference in different countries' budgets right at the start of the talk. Different countries are willing to pay different amounts for health gains depending on how big their health budgets are, and there's not really a way around that. There will sometimes be things that are cost effective in one country and not in another.
Thank you, Lucy. Similarly, so with this idea of, with this idea of what is kind of effective and how we should be thinking about kind of implementing that. We've had a question from Antonia to ask, is there a mechanism in the NHS that would prevent GPs from saving money and not sending or referring patients, even when it would actually be good for patients?
I think we've got the QOF, I can't remember what it stands for, Quality Outcomes Framework, which is financially linked. So there's a financial incentive tied to that. GPs get more money if they treat patients in accordance with guidelines, basically. So that means, and it's for, I think, a certain number of conditions. So things like diabetes. So if they get the recommended number of appointments with the recommended number of health professionals, and they're being given all of the correct referrals and treatments and so on, the GP gets more money for that. And that's a way of incentivizing what we call sort of value-based care. If a GP's kind of trying to save money by not referring, if we can't see it, we don't know it's happening, which is always the challenge. And it can be tricky to know what's an appropriate referral and what's an inappropriate referral. So one of the classic examples might be something like headaches, because that's always the one that people Google and find out they've maybe got brain cancer. If you've got a headache and you've got it coming back and you keep going to the GP, and then eventually after a year they refer you and you find out you've got cancer, and that's an incredibly sad situation, your instinct is going to be GPs should refer more people, because then I could have been, treated earlier. But the problem is, from the GP's point of view, they may be seeing a headache a day, and of that they might see a brain cancer every 20 years. So it's really, really tricky to know whether a GP is failing to refer because of money or because they actually made a reasonable risk assessment. The problem with what the job that GPs have to do is that they're having to make those risk assessments all the time. And the problem with any kind of probability-based decision making is that there's always a risk that the person in front of you is the 1 in 1,000 or the 1 in 10,000. So if GPs are sort of deliberately not referring for systematic reasons. So that could be a bias, that could be because they're incentivized to try and save money or something like that. Then measurement would be the solution to that, knowing that it's happening, being able to measure it. But unfortunately, I think a lot of these things are just, that's the reality of what general practice is. And unfortunately, some people are going to fall on the wrong side of that risk judgment, and we just have to try and develop the tools, the diagnostics, and so on to try and minimize that number of people.
Yeah, I agree, Lucy. I think it's a really complex situation, and I think that's highlighted the complexity of it beautifully. Let's go on to a little bit more international comparison, and Michelle has asked, do we understand why Iceland, despite its spend, is ahead in terms of health outcomes? And that was something that you mentioned, I think, in your beginning slide
early on.
Yeah.
I don't know. I just thought it was fascinating that Iceland seems to show up so high in life expectancy. There are, if you sort of if you look at those, and you can go on the OECD website and you can play around with that data. If you just Google OECD life expectancy, they've got loads of these graphs. They're really interactive, so do go and have a play. It could be they're a very small country. There's, I think, only about 300,000 people in the whole of Iceland, so your capacity for doing preventative interventions is going to be that much easier because you don't need the same scale. They probably got a very good diet with lots of oily fish. I really don't know. I just thought it was really interesting. I will say lots of countries do track. You know, I pulled out some examples that are very striking to illustrate the point, but lots of countries do. You know, Germany and France sort of roughly track with where they are in terms of both spending and life expectancy. So Iceland is a little bit of an outlier. But if anyone is Icelandic and knows, I would love to find out.
It's a fascinating country, Lucy, and a really fascinating observation as well. So I'm going to ask, we've had a couple of questions about QALYs, quality of life measurements, and I just wonder, Lucy, if you could explain a little bit more. So we've got some, a couple of questions asking, how's a QALY actually expressed? Is it actually a cost? And could you give an example of kind of a high and a low QALY?
Okay, yeah. So in terms of how it's used, it's not a cost, but we use a threshold to kind of turn it into a cost. So the cost you might see in terms of QALYs is what we call the threshold, which is the in the UK at the moment, NICE's threshold, which is the point at which they say that things are no longer cost effective, it is £20,000 per QALY. That does go up. It goes up to 50,000 if it's end of life, and I believe that there's a special circumstance where it goes up to over £100,000 per QALY. So the QALY itself is not a cost, but you can use this threshold to turn it into one. So if there's a gain of, and this is how net benefit is calculated, if an intervention gets you 3 QALYs and your threshold is £20,000 per QALY, then your willingness to pay for those 3 QALYs is £60,000 in total. So if the cost of your intervention is less than £60,000 in total, then you should pay for it because you're sort of saving money. The benefits are worth the cost. So that's one way that we can turn QALYs into a monetary value to then make that judgment. But QALYs themselves are separate. And what we do when we're calculating our cost effectiveness ratio, our ISA, is we take the difference in costs of the usual care and the intervention and the difference in QALYs of the usual care and the intervention, and that gives you a ratio, which is your cost per QALY, in terms of that QALY gain over your usual care. It is a little bit mathematical. As I say, really the thing to go for is just always look at that cost effectiveness plane, because there is no information in the statistics that is not also in that cost effectiveness plane, and that's a lot easier to interpret.
good advice, Lucy, and very true. Qualies were always very, very complicated when we were doing clinical trial work. A nice pictorial graph, much easier to interpret, and very similar information. We've just had a question about the first slide, Lucy. The slide which shows the spending growth had a gold line. Could you just tell us what that stood for?
Yes, let me try and remember. Let's go back to that. Yes, this is a percentage of GDP. So this is exactly the same statistic as you then have on our health spending as percentage of GDP graph on the next slide. So the gold line is the same value, but expressed as a percentage of GDP rather than as a real terms health spending. I should mention actually that the blue line, I don't think I mentioned, is inflation adjusted. So that blue line is in 2017 prices. So this is a real increase in spending. It's not just inflation that's accounting for that. But what we can see comparing the blue line and the gold line is that essentially although the real world spending has gone up quite dramatically, the spending as a percentage of GDP has gone up less, which means that essentially GDP's got bigger, which is not a huge surprise.
Yeah, thank you, Lucy. Yeah, that really makes sense, and that absolutely explains where that line lies. Somebody has asked if there is any diagrammatic explanations of QALYs.
Diagrammatic, yes, there are some. I didn't put them in because when you get into the discussion of how to construct QALYs, you need at least an additional 15 minutes. There are. I can try and find some. I don't have one to hand right this second. Typically what you will see is a graph where you've got length of life on the x-axis and quality on the y-axis. And so you can plot in exactly the same way as you do with costs and effects. You can plot your sort of length of life and your quality of life. And so then you just take the area under the curve. So then you just look at underneath that curve. And that's how you calculate your quality adjusted life years over time. I do have some of those on my computer, but I would have to take you on a tour of my desktop to try and find them. But you can probably, with some Googling, you can probably find some if you're curious. The person who talks really well on this, and he has probably got some videos on YouTube and things, is a guy called Carl Claxton. Carl with a K, Claxton with a C. He's the guy who really knows his stuff about QALYs. He's done a couple of shows on the BBC, but I think he's probably on YouTube as well. He's got some really great sort of diagrams of how QALYs are constructed, if you're interested.
That's brilliant, Lucy. Thank you very much for that. I think what it's shown is that there is a huge public interest and appetite for health economics. So I think this is an area that we might have to follow up with a longer session when we're able to. I think I'm just going to finish with a sort of a final question that's come through about a sort of specific example, and this is where the new generation of biologic treatments for asthma fit into this sort of analysis. So Peter has commented on this and said that they're very expensive, but they can make really big improvements in quality of life. And he's asked how the judgments would be made for something like this.
Exactly the same way as for everything else. And really they should be. There's lots of arguments sort of particularly coming out of pharma saying, you know, our drug is different because the treatments, you know, the benefits exist far in the future or something like that. But actually, there's no particular reason why the sort of almost the manufacturer of the drug should have an effect from our point of view, from a health economist point of view, on whether we pay for it or not, because again, what we're looking for is that health maximization. So we're looking at spending that budget in the way that's going to give us the best health outcomes. A lot of these drugs They do give very good health benefits, but often they come with absolutely extortionate price tags as well. Sometimes there are good reasons for that. So if you've got a very, very rare condition, it's very, very difficult to do all the R&D, do all of the manufacturing, do all of that, and then still be able to sell it for what, at least with a little bit of profit on it without charging a huge price, and that's a special case. But in general, with these kind of biologics and these new sort of personalized medicine treatments, actually a lot of the time they're just the prices that they're being charged incredibly high, and in those cases we do have to really stick to our thresholds, because, you know, as we've seen, you could have a really spiking expenditure, or worse than that, reallocation of money from more effective treatments to less effective ones, like the example of joint replacements. Some of the reason that we're seeing these issues now isn't just caps on spending, it's also things like the Cancer Drugs Fund. So the Cancer Drugs Fund was launched in 2010, and any sort of life-saving cancer drug could be paid for out of it. And what we saw when the evaluations were done was the budget ballooned. Most of the drugs that were being paid for got people at most 1 or 2 months of additional life. Only about 20% of the drugs covered by the Cancer Drugs Fund were actually clinically meaningfully effective at all, so had any benefit for survival. So one of the reasons we now don't have as much money to spend on things that work is because we spent all of that money on things that don't. So with these biologics and things like that, you have to be really careful that they are worth spending that money for.
Absolutely, Lucy, and you have just beautifully illustrated there how vital health economics is as a field of research, and how vital it is that we do have really good public and patient involvement in it as well. We could go on talking about this, I think, all afternoon. It is a really fascinating area, and it just has so many discussion points with it. So as I say, I think we will definitely need to do some follow-up events, maybe, if there's an appetite for that. But in the meantime, I think that just leaves us to say thank you so much, Lucy, for your time this afternoon and for giving us such an informative and clear presentation. And thank you to all our attendees who've taken the time to join us and engage with us in the questions and answers and comments. Absolutely brilliant questions and really insightful comments. I'm just going to draw people's attention finally just to the shared email address that we have. That is Oxford PPI training, all one word, at gmail.com. And if anybody has any sort of feedback they'd like to give us about the presentation or any of the kind of technical side of things, please do feel free. As I say, we hope that we're going to be able to do this again, and we would like to be able to refine it to make it as good as we possibly can. But otherwise, I'd just like to again thank everybody for coming, and to you, Lucy, as well, for your great presentation. All right, so we hope we see you all again soon. Bye-bye.